Well, good afternoon. I'd like to welcome everybody again to another edition of our SMFM Fellow Lecture Series. As usual, we'll have a talk from a local expert on one of our MFM topics, followed by the opportunity to ask questions and answers at the end of the lecture. The next upcoming lecture continues our research series and will be given by Dr. Allison Cahill on September 19th on confounding and biases in cohort studies. Today, I'd like to introduce from UTMB Obstetrics and Gynecology, Dr. Luis Pacheco, who is going to lecture on sepsis and pregnancy. This is a great topic for us, and we've been trying to add more critical care topics to the lecture, so hope everybody finds this valuable. At this point, I'd like to turn it over to Dr. Pacheco, and then be ready for questions and answers at the end. Thank you.
All right. Thank you so much, Dr. Goodnight. Thank you for having me, and hello to everyone. If you actually look at the first slide, I'm going to cheat a little here because I think this is a great opportunity to try to talk about something a little different. If you see the title is actually sepsis, and it doesn't say during pregnancy, and I'll tell you why. It's because when you do ICU, you realize that most of the things you do in the intensive care unit, you do very similarly during pregnancy. And I don't want to give you a lot of, spend a lot of time on pyelonephritis and chorioamnionitis and how to diagnose those and which antibiotics to give, because you all know that better than me. What I want to do with this lecture is I'm going to walk you through pretty much what we do daily in the ICU on a patient with sepsis and how most people manage patients with sepsis, because I believe that that's what you all need to be more in contact with. So sepsis actually continues to be a huge problem. It is the most common cause of mortality in the intensive care units in the Western world. And obviously, the more severe the syndrome, then the higher the mortality. So if you have someone with septic shock, you're looking roughly like at a 50% chance of dying. This slide right here is a simplified cartoon of what happens in sepsis, but it has most of the things that you need to know, and then if you understand this, you will know where most of the treatment strategies are going. Whenever you have an infection, it doesn't matter what it is, if you develop sepsis and severe sepsis and septic shock, what happens is you have a massive inflammatory response that is going to be actually out of proportion to what you need to take care of your infection. So neutrophils and monocytes and lymphocytes and all the inflammatory cells are going to actually liberate massive amounts of cytokines, and they're going to cause changes pretty much in every organ of the body. But in general, elastases, proteases will go and cause diffuse endothelial injury. So you're going to start third spacing, albumin will leak, will pull the fluid, and then you're going to become hypovolemic. And not only that, but there's going to be a massive activation of nitric oxide. So you're going to be profoundly vasodilated. So your blood pressure is going to drop because of the drop in systemic vascular resistances. And all the fluid that you give, which you have to give, unfortunately is going to third space, more or less, depending on the severity of the disease. And this is why patients actually require massive amounts of fluid initially when you treat them. That diffuse endothelial injury is going to be followed by, platelets adhering to the injured vessels. And one thing that you all need to understand is that when you have inflammation, invariably, you're going to have activation of the clotting cascade. Because when you get inflammation, the monocytes mainly, but also neutrophils and the endothelium, as part of their activation, they're going to express tissue factor in the surface of their membranes. And when they expose tissue factor, as you recall from the little cartoon of the clotting cascade, the tissue factor will bind factor 7, and that's going to go to the common pathway, and you're going to start clotting. So whenever you have inflammation, you're going to have activation of the clotting cascade. And if you activate this clotting cascade and you start generating thrombin all around your microvasculature, then that's nothing but DIC. Now, DIC in this setting is not going to manifest as hemorrhage. Because in sepsis, I mean, you might have a wound there, but it's been 2 days and it's not actively bleeding. But this is going to manifest as just clotting all around the circulation, and it's going to manifest as organ ischemia and multi-organ failure. So all these little clots in the kidney will cause kidney injury, and you'll stop peeing. And all the little clots in the lung will favor ARDS, and all the little clots in the heart will cause actually myocardial infarctions, and the little clots in the gut are going to cause gut ischemia. And the little clots in the liver are going to cause liver dysfunction. And then the other thing is that people have this belief that the cardiac output is actually, that the heart is healthy during sepsis, and that's actually a misconception. The cardiac output is going to be elevated if you measure it through a transthoracic echo or you put a swan, which rarely anyone will do anymore for sepsis. But if you actually document the cardiac output, yes, it's going to be elevated, but it's going to be elevated. It's going to be elevated because you're so vasodilated. There's no resistances. So even if you have a poorly systolic function of the heart, you'll still be able to actually push decent stroke volume. So you got to be careful with this, because as we go through the treatment, you're going to see that when you give someone vasopressors, which are medicines to squeeze the vessels, to increase the blood pressure, then what's going to happen? If you have a sick heart, you're going to unmask the heart dysfunction. So you need to take that into account, and we're going to talk about that in a little bit. So, all right. Let me go back here. Okay, I don't know why that is not showing what should show. But mainly, what this slide was supposed to show is what is systemic inflammatory response syndrome. And that is something that you can find, and you can Google it, it's going to be there. So systemic inflammatory response syndrome mainly is going to be someone that has two of tachycardia, meaning a heart rate more than 90, tachypnea, meaning a respiratory rate more than 20, or a PaCO2 less than 32, leukocytosis more than 12,000, or leukopenia less than 4,000, or bandemia more than 10% of bands, or either hypo or hyperthermia, more than 36, less than 36 or more than 38 Celsius. So that is actually a super non-specific definition, as you all know. So many years ago, close to 20 years ago, these definitions came out that you can see there, saying that sepsis is anyone that has an inflammatory response syndrome secondary to infection. So if you have a heart rate of 92 and you have a temperature of 38.1 in the setting of pyelonephritis, if you want to say it, then you have sepsis. If you show dysfunction of any single organ, then that's going to be severe sepsis. So if you become oliguria, or if you elevate your LFTs, or your platelets drop because of hematological failure, or you develop pulmonary edema from lung injury, because all these cytokines are going to injure your alveoli, so you might third space there as well. Or if you become confused, then that will make you severe sepsis.
And it's Dr. Wolf over at Maternal Fetal Medicine. Good. Remember when you installed that software for that lecture series on my computer over at Maternal Fetal? Well, right. So we're doing another one today, and just like last time, it keeps kicking me off the audio. So I wondered if we ever figured out, am I wirelessly connected or am I hardwired? And is that the potential problem?
Hello?
I wanted to make sure that my computer is hardwired into the internet.
Can anyone hear me? Hello? All right, I don't know what that was. I'm just going to keep on talking. And then septic shock is going to be patients that actually develop hypotension despite fluids, and then you have to give them vasopressors.
Yep.
So that definition, as I said, is extremely sensitive but poorly specific. Pretty much everyone in an ICU going to have systemic inflammatory response syndrome.
So can I turn the wireless off?
Hello. Come in here somewhere else. Anyways,
Yeah, I'm just gonna disable. Oh, okay.
in terms of the previous definition, just give me a sec so someone can check it.
Yep. Like a little wireless signal.
How come I? Oh.
See, that's the only thing.
Okay. All right. I don't know. So whoever joins, try to mute it afterwards so we can keep talking. So since that definition is so non-specific, later another definition came which actually has the same problems. It is very sensitive but non-specific. So all those things that you see there, if someone actually suspects and is infected, if you see any of those things, then you would actually be concerned that patients have sepsis. So if you have someone that has an infection in the floor and they actually become confused, you gotta suspect that they actually are having brain dysfunction from infection. If they drop their platelet counts, it's not because they have preeclampsia. It's probably because they have thrombocytopenia secondary to activation of the clotting cascade. If they become oliguric, if they actually have they have hyperglycemia, if they become distended in the bowel from ischemia in the bowel, any of those things that you can see.
I should have a laptop, but you can't do anything with this laptop, so it doesn't help me. Like, I can't put any programs on it or do anything with it, so.
Can you mute that?
Yeah. Apparently they said it's better just to buy your own.
Can you hear me that good night? All right, I'm going to try to continue. So if you actually have any of these things in the presence of infection, then you should actually be alerted that it is secondary to sepsis. So what are you going to do when you have someone that you suspect has sepsis? Well, this is going to be the things that will actually improve your outcomes. And these are the things that are most important. The rest that we're going to talk about, it is important, but it's not going to change the outcomes the way these things are. First thing is you're going to obtain blood cultures and urine cultures and sputum cultures, depending on what you're looking for. Try to get as many cultures as you can. And if you have any vascular device, if you have a central line, if you have an arterial line that has been there for more than 48 hours, then you get a culture from there as well. Once you've gotten the cultures, then you go ahead and start antibiotic therapy. You're going to start empiric broad spectrum antibiotics. And, you know, antibiotics is a whole other talk, but in general, try to cover, this is in general, gram-positives, gram-negatives, and anaerobes, and titrate according to what you have in your hospital. If you have a bunch of MRSA in your hospital, then you might want to start with vancomycin. If you have a bunch of Pseudomonas, multi-resistant, then you might want to start with cefepime, or you might want to start with Cipro as opposed to levofloxacin. It depends on what you have in your hospital. And then once you start the antibiotics and you got your cultures, you achieve surge control. So if you have an abscess, it needs to be drained. If you have something that is surgical, it needs to be removed, etc. Those things are going to be done usually earlier. And once they're done, then the intensive care management of these patients comes. And the main problem, or the main thing we're going to do is, we do know that patients, especially early in sepsis, are going to need a lot of fluid. And they're going to need a lot of fluid because remember from the first slide, we saw that, that there is profound vasodilation and your third spacing. So you need to fill actually your vessels with something. And fluids are going to be the mainstay therapy. I don't know if you know, but those of you that have heard about like vasopressors for a long time, many years ago, when people talk about Levofed, which is norepinephrine, people used to call it living dead, because everyone died when they got norepinephrine. And it's not because of the norepinephrine, it's just because people were using it without knowing how to use it. If you give someone with sepsis vasopressors, and you don't fluid resuscitate them before, then imagine, you know that the vessels are empty, and now you're squeezing the vessels, so you're going to have horrible organ ischemia. So you'll end up with kidney injury, liver injury, heart injury, lung injury, brain injury, gut injury, and then you die from multi-organ failure. So fluids are going to be the first-line treatment. Now, and this is going to be probably what we're going to spend the most time here. The first question is going to be, which fluid are you going to give? So you're going to hear things, you can hear a lot of people saying, oh, I like to use crystalloids. So other people say, I like to use colloids. The bottom line is that there's no difference in outcomes based on the literature available. The largest trial, which is on that slide, the 2004 paper, which is the SAFE trial, it compared 4% albumin with crystalloids, with normal saline, and there was no difference in outcomes. This was on a heterogeneous population of ICU patients. Obviously, pregnant patients were not included, but I have no reason to believe that it's going to be different during pregnancy. So there's no difference in outcomes. There's actually a recent paper just this month on critical care medicine, where actually, again, they show no difference in outcomes between crystalloids and colloids, and they didn't even show that with colloids you would be able to revert the shock faster. What you got to know is that crystalloids, meaning normal saline, plasmolide, lactated bringers, any of those, they have a very short intravascular half-life. So the half-life is only like 30 to 60 minutes. As opposed to, for example, albumin, which is going to be the colloid of choice to use in sepsis. You can use albumin at 5% or 25%. The half-life of albumin, the intravascular half-life, is 16 hours. So those who like colloids are going to tell you, well, I like to give albumin because it's going to stay longer in the intravascular space. And that's probably right. In the first 24 hours or so, you're going to give less albumin and achieve the same results as crystalloids. But then tomorrow or the day after tomorrow, that albumin is going to leak to the third space. It's going to increase the colloidosmotic pressure in the interstitium and pull even more fluid. That's why there's no difference in outcomes. You're just going to need your fluid regardless of what it is. There's one that we're going to talk about it for those of you or in your institutions where anesthesia likes to use Hespan, hydroxyethyl starch. You should not use that in sepsis, and we'll talk a little bit about it. So once you know that you can actually, that you need to give fluid, this is what I told you about Hespan. This is actually a recent paper on the New England Journal of Medicine showing that Hespan, even the new generation products, which is that one that is cited there, 130/0.4, which just refers to the molar substitution. There's no need to know that. But in general, even the newest preparations of Hespan, hydroxyethyl starch, have been associated with kidney injury and have been associated with increased mortality in sepsis. So don't use Hespan in sepsis. Use albumin or use crystalloids, either or. And as I said, there's going to be no difference in outcomes if you choose to use albumin or crystalloids. Now, the main problem is now that you know that this patient has sepsis and is hypotensive and needs fluid, and you already know that you can do either normal saline or LR or albumin, now the question is going to be, well, how much am I going to give? And when am I going to stop? So the idea of just saying, well, give 1 liter and see what happens, that actually is incorrect, and you should not do it. Now, obviously, I mean, if the patient is hypotensive, give the first liter. They're going to need at least a couple of liters. That's not where the problem is. The problem is when you've given already 3, 4, 5 liters, and then you start asking yourself, does this patient need more fluid or not? That's a problem, and that's what we're going to talk about. But once you've given that first or second liter of fluid, before you give the third one, you might ask yourself, well, maybe just giving the fluid and saying, let's wait and see what happens, meaning hopefully the blood pressure will come up and the heart rate will come down. The price to pay if you give the fluid and that doesn't happen is a little bit high, because you can see there all the problems you can get from all that fluid if you cannot, if it's not indicated. that fluid is going to third space into the brain, and you're going to worsen cerebral edema. Same thing in the lung. Same thing in the heart. The left ventricle actually becomes swollen, and then it's going to be stiff, so you develop diastolic dysfunction, and that increases your chances of pulmonary edema as well. You're going to get gut edema, so you increase your chances of abdominal compartment syndrome. And if you have an anastomosis in a bowel, or you have a wound, or you have a graft that has been recently transplanted, all this fluid, if it was not indicated, will just cause edema and dysfunction. So as you can see, the idea is, once you give fluid and you start giving fluid, what you need to try to find is something that will tell you, stop giving fluid at that time. So how do you reach that point? Central venous pressure and the pulmonary artery occlusion pressure obtained through a swan are extremely poor predictors of fluid responsiveness, and they should not be used to guide fluid therapy. And that's what pretty much all the ICU literature shows at this moment. I know a lot of people actually like to use these, and still, like in the early goal-directed therapy, which is a trial in 2001 from Emmanuel Rivers, they use CVP to guide fluid therapy. You cannot say that it's the CVP that or management or the CVP goal that actually improved the outcomes in that trial, because it could have been actually the early fluid, it could have been the resuscitation titrated in SCVO2, the use of inotropes, etc. So there's no evidence, there's no literature actually that justifies keep using CVP or the wedge pressure for fluid responsiveness. Instead of using those static measurements of preload, then what you all should be using is dynamic measurements of preload. And that's what we're going to talk about, like passive leg raising and pulse pressure variation. So let's say you actually come and you have a patient with sepsis and you give 1 liter, you give 2 liters of fluid. I mean, most guidelines will tell you start with 20 to 30 mLs per kilo of fluid. And let's say you give that fluid. And your goal in sepsis is going to be to maintain a mean arterial blood pressure above 65 mercury millimeters. You can say that that's arbitrary. Yes, it's arbitrary, because probably someone who is 18 years old might perfuse their organs fine with an MAP of 50. And someone who is 80 years old with diffuse atherosclerotic disease, chronic hypertension, might need a higher MAP. But most people will accept that an MAP around 60 to 65 should be your goal. So if you already given a couple, 2-3 liters of fluid, and still your MAP is below 60 to 65, and things don't look good, then what you need to do is not look at the CVP. What you need to do is look at this slide, and then you remember the starting principle. If your heart is on the steep portion of this curve, then it means that if you give preload, you're going to get cardiac output. You're going to recruit cardiac output. And that is the main reason of giving fluid. So how do you know that you're in that part? Well, when you are in that part of the curve, you're going to have pulse pressure variation. That's what we're going to talk about. Most patients that are really sick with sepsis, and you are debating about this, are going to be intubated. So most of these patients are going to be on mechanical ventilation, and they're going to be in sinus rhythm. I mean, yes, you can have AFib, you can have flutter, you can have whatever you need, but most patients are going to be in sinus rhythm. They're going to be in sinus tachycardia. So if you put the patient on the mechanical ventilator and they are in sinus rhythm, then you can just go there, increase the rate of the ventilator, increase the tidal volume to 8 to 10 mLs per kilo. So let's say, I just did this morning like 2 times on 2 patients. So you just go there, let's say you increase the respiratory rate to 20, you increase the tidal volume to 700, and you just sit there until you take over the breathing and the patient is not triggering anymore. And once you do that, then you look at the arterial line tracing. Most of these patients are going to have an arterial line as well. And when you look at the arterial line, you're going to see how the pulse pressure is going to variate depending on if you're an inspiration or you're an expiration. If you are in inspiration on a ventilator, when the ventilator fires and gives the tidal volume into the chest, the pressure inside the chest will increase. So you're going to have less blood coming back into the right ventricle. The preload to the right ventricle is actually decreased. However, the lungs normally are full of blood. They're like sponges. So when the ventilator fires at that same time, it's going to squeeze the lungs, and the blood that is pooled in the lungs is going to go through the pulmonary veins into the left side of the heart. So the left side of the heart is going to get more preload, and during inspiration on a ventilator, the afterload decreases. So when the ventricle squeezes during inspiration, it's going to increase the stroke volume. The opposite is going to happen during expiration. When you expire on the ventilator, more blood, because the chest pressure will decrease, more blood will come back to the right side of the heart, and then less blood will come to the left side of the heart because you're not squeezing the lungs anymore. So if the left heart gets less blood, the stroke volume is going to decrease. So how does this look? It looks just like this. If you actually see the arterial line tracing, you will see how the amplitude of the pulse pressure varies. And this is going to predict fluid responsiveness like in 80% of the cases. This is more powerful than an echo, more powerful than a CVP, more powerful than a pulmonary occlusion pressure. And this is what most intensivists in the world are using to predict fluid responsiveness. So once you see this pulse pressure variation, what are you going to do? You're going to give more fluid because you have an 80% chance that you will recruit cardiac output. And you will give fluid until either you achieve your desired mean arterial blood pressure or until you lose the pulse pressure variation, meaning that you're already on the plateau of the curve, and then you will have to give them pressors. The patients that are not on a ventilator, you cannot do the pulse pressure variation. So there's a bunch of non-invasive devices now to measure cardiac output. All they need is an arterial line that you hook them to it. It'll give you continuous cardiac output. Or there's another one. There's other ones that you just put like a little cuff, blood pressure cuff on the finger, and it will actually give you continuous cardiac output. So if you're debating, if you happen to have the luxury of having one of these monitors, I don't have one, even though I've been asking for it though, but I don't have one. But if you have one of these in your hospital, and you are debating if a septic patient needs or doesn't need fluid, and it's not on the ventilator, it's not like you're going to intubate them to see if they have pulse pressure variation, right? You won't do that. So what would you do? Well, hook them to this device, and then elevate their legs. And when you do passive leg raising, you're injecting 300 cc's of blood into the central circulation. And if you do that and the cardiac output increases, that patient actually will recruit, and then you will give them fluid. So let's say you gave the fluids and you could not achieve an MAP of 65, and you have already lost your pulse pressure variation, and you're like, well, this patient doesn't need any more fluid, and I know that more fluid is going to cause more harm. Because there's something that you need to understand, and it is that in the intensive care unit, the more positive your balance of fluids is, the more your chance of dying is. So fluids are needed, they are life-saving, but you need to know when to stop. So let's say you lost the pulse pressure variation, and now you decide that because your goal has not been achieved, your MAP is still not 65, then you say, well, I'm going to start a vasopressor. So which vasopressor are you going to start? The Sepsis Surviving Campaign, which the latest is 2008, it's that reference you have on that slide, actually says that you can start with either norepinephrine or dopamine as first-line pressors. Pressors need to go through a central line, because if they go through a peripheral line and they extravasate, you can necrose the whole hand and you lose the extremity. That doesn't mean that if you don't have a central line and you need it, you cannot start it. Just go ahead and start it, but then you get ready to place a central line, and then when the central line is ready, you can just switch the pressor from the peripheral to the central line. The Sepsis Surviving Campaign says that the second line pressor, if Levofet doesn't work or dopamine doesn't work, depending on which one you chose, the second line is epinephrine. That's what the Sepsis Surviving Campaign says. So if you actually, and this is also a big debate, personally, I don't think there's any difference between one and the other, because what makes the difference is early antibiotics, early surgical or surge control, and early fluid resuscitation. There are some theoretical concerns about using dopamine. I don't use dopamine just to, I was trained using Levofet, and I use Levofet most of the time. But there's nothing wrong with using dopamine. I mean, dopamine, yeah, it might decrease the immunity, so they say, by decreasing prolactin. It's for sure, and I'm sure everyone knows this already, dopamine doesn't help the kidney. Actually, it hurts the kidney, and it worsens medullary ischemia. Dopamine is a diuretic, so why would you want to give a diuretic to someone who is hypovolemic? Doesn't make a lot of sense. There's articles saying that it increases, but there's also articles saying that it decreases the GI perfusion. And there's no question about it that dopamine is way more tachyarrhythmic than levophed, than norepinephrine. Because remember that dopamine increases the blood pressure mainly by increasing the cardiac output. Norepinephrine increases your blood pressure mainly by increasing your systemic vascular resistances. So the largest randomized controlled clinical trial available comparing levophed or norepinephrine to dopamine is this paper here in the New England Journal of Medicine 2 years ago, and it showed for sepsis no difference in outcomes. Then there is this meta-analysis that just came out this year on critical care medicine that actually says that you have a higher chance of dying if you get dopamine. So they recommend using levophed. Again, the bottom line is not really, patients are not going to die because you use dopamine or because you use levophed. The likely thing that patients are going to die is because of late recognition of the sepsis, late start of antibiotics, late start of fluid therapy. Once you reach the point of a pressure, probably the choice of either or is not going to make a big difference. Most people in the U.S. will actually use levophed, and since this meta-analysis came out, at least here where I work, like everyone quotes this to use levophed, but we all use levophed, so it doesn't really help us that much. Now, one thing that if you start pressors during pregnancy, this is probably the only time I'm going to mention pregnancy here. Some people might say, well, but the pressures are going to cause ischemia to the uterus. Well, if you have someone with a mean arterial blood pressure of 40 and a heart rate in the 180s, I'll bet you they're not getting very good perfusion either. So you need to resuscitate the mother, and then the things with the fetus will actually improve. So you cannot withhold pressures on someone that really needs them. Now, remember we talked at the very beginning the fact that the heart is actually dysfunctional in sepsis. So you already gave the fluids. You started the levophed infusion. And then, let's say you notice that you write there, start a levophed infusion and titrate to an MAP above 65. And while you're doing that, the nurse comes to you a couple of times in the next 2 hours and tells you, listen, doctor, every time I need to go up, I need to go higher and higher and higher on the levophed infusion because the blood pressure kind of goes up for a little bit, but then it drops. So the thing you need to know here is that 60% of patients with sepsis, they actually have an ejection fraction of less than 45%. They have systolic dysfunction. All the cytokines, some of them like TNF-alpha, interleukin-1, platelet activating factor, nitric oxide, oxygen-free radicals, all of those inhibit cardiac contractility. So your heart is sick from the get-go. It doesn't squeeze well. And you are vasodilated, so the heart doesn't care because you're so vasodilated that you can empty and maintain a decent stroke volume. But what happens when you give levophed? I told you that levophed increases the blood pressure mainly by squeezing the vessels, by increasing the systemic vascular resistances. If you squeeze the vessels and you increase the afterload, what's going to happen to the heart? It's going to start failing. So you will unmask the heart dysfunction. And that happens in pretty much 34% of people that get monotherapy with levophed. So if you do that, and this is happening, what do you need to do? You need to add something to help the heart. Those medicines are called inotropes. So you can use dobutamine or you can use something called milrinone. Dobutamine is the one for which there's more data in sepsis. So I hope that actually makes sense. Now, if this is happening and your nurse, and this is the way I want to give these talks, exactly how it happens in the ICU. So let's say the nurse says, well, this is happening, and you're like, well, maybe the cardiac output is being compromised. How can you measure the cardiac output? So if you actually have one of those non-invasive devices, by all means, go ahead and use it. If you don't have it, You can do a transthoracic echo, but you're not going to get that at 3 in the morning, someone that knows how to calculate cardiac output by transthoracic echo. I will advise you not to float a swan because it doesn't improve outcomes. So one thing that you can do at the bedside is do a SCVO2, because these patients are going to have a central line likely. You just get a sample from the central line and then get a venous gas and see how saturated the hemoglobin is. As you can see in this cartoon, like on the left, you see how the hemoglobin comes to the tissues with a bunch of oxygen, and then it leaves the tissues normally with more than 70% of its saturation. The normal tissue will only extract 20 to 25% of the oxygen that is delivered. So what happens if you get the blood sample from the vein? You start the leave of it. And then you get a blood sample from the vein, and the SCVO2, which is nothing but the saturation of hemoglobin, right there in the central circulation on that line that is at the tip of the superior vena cava with the right atrium. You get that sample. And let's say it says it is actually 50% saturated. So that is actually a marker of decreased oxygen delivery to the tissues, meaning the tissue is extracting a lot of oxygen, and that's why the hemoglobin came back saturated only at 50% and not at 70%. And that is actually that actually reflects a low cardiac output state. So you might be hurting that patient, and that patient might need an increase in cardiac output, and then you will increase dobutamine based on that. If you ask me the SCVO2 in pregnancy, as far as I know, no one knows the exact value. There is a paper by my boss, actually, by Dr. Hankins, some years ago, where they measured not the SCVO2, but the SVO2, which is slightly different. They measured and they found no difference. But again, I think we need to find out what the normal SCVO2 is and those kind of things, but we need to become more hands-on, start doing things and treating patients, as opposed to saying, none of this applies to pregnancy, so I don't need to know it. I think we all need to know it. And this is just something that you can use. If you don't trust this, then get an echo or get a non-invasive cardiac output machine and see if you're hurting the cardiac output. Now, in terms of vasopressin is certainly not a first-line pressor in sepsis. The largest trial available in the New England Journal of Medicine 4 years ago showed that it doesn't work. However, that trial was a little different because in that trial, all they did was patients that were on Levophed doing okay, they randomized them to either vasopressin or not and found no difference. And I'll tell you why there might be a place for vasopressin in sepsis regardless of these findings. The reason why you give vasopressin or you consider giving vasopressin in sepsis is because you have a limited amount of vasopressin in your hypothesis. And when you have a stress situation like sepsis, cardiac surgery, etc., you secrete all this vasopressin, and vasopressin is good for you, right? It's going to help you squeeze your blood vessels and maintain your blood pressure. It will help you increase the cortisol secretion. It will retain water in the kidney. So it helps you stay hemodynamically stable, if you want to call it like that. But it's just a limited amount of vasopressin that you have this available for the acute situation. Then you're going to have a relative deficiency of vasopressin, and that's where the whole idea of giving vasopressin in sepsis comes from. Sometimes you can have patients, let's say the same patient we talk about, you gave the fluids, you gave the Levophed, then the blood pressure dropped, you got an SCVO2, it's less than 78%, you gave dobutamine, and still the blood pressure is not that good, MAP of 50 if you want to, and the heart rate is in the 180s because of tachycardia from the Levophed. Those patients, you can probably say that they have catecholamine-resistant septic shock. Despite the catecholamines, they're still not reaching the goal that you need to. And you have already gone through the fluid resuscitation and everything. In those patients, you can consider adding vasopressin. The dose of vasopressin is 0.04 units per minute, and you never titrate it. That's just a physiological dose. And you will not increase it because higher doses will cause coronary spasm, skin spasm, renal spasm, splanchnic spasm, and you might actually hurt your patients. There's not a lot of data on vasopressin in pregnancy, and it can actually bind to the V1A receptors in the muscle and cause contractions. So if you don't need to, don't use vasopressin. Now, if you have that same patient that you've given catecholamines and you cannot achieve the blood pressure that you want, and you say, oh, let me just see if they have pulse pressure variation again, and you check again, no pulse pressure variation, so you know they don't need any more fluids. You're given the levofed and the dobutamine because you documented a drop in the SCVO2 that we spoke before, and still the blood pressure is not doing what it's supposed to. Then someone might come and tell you, what about steroids? So steroids in sepsis, the reason why you would want to use steroids in sepsis is because cytokines inhibit the secretion of CRH, ACTH, and cortisol. So your whole axis is going to be dysfunctional. And remember that if you don't have cortisol, you will not upregulate in the blood vessel the receptors for catecholamines. So it doesn't matter how much catecholamines you give. If there's no receptors, it's not going to work. So that's the principle of saying, let's give steroids to people with septic shock. Now, there's a lot of studies, and there's been a lot of controversy about this. And the bottom line is that this right here is the largest trial available that shows an improvement. This was an article 10 years ago in JAMA by Anane, and this is the one that actually showed that giving steroids to patients with septic shock improved mortality. Now, someone might come and tell me, oh, I read a corticals trial in the New England Journal of Medicine saying it didn't work. Yes, but they are different populations. In the corticals trial, they gave steroids to people that were hemodynamically stable. In this trial, and this is actually what you should be doing, and this is what the current guidelines say, if you give vasopressors to a patient with septic shock, and these patients actually fail to maintain a systolic blood pressure above 90 for 1 hour, despite the catecholamine, then you give them steroids. How are you going to give them the steroids, and which steroid are you going to use? In the ANAN trial, that's the corticals trial that showed that it didn't work. And this is pretty much what you need to do. I just skip a couple of slides there just because of time, but you don't need to do a ACTH stim test. You don't have to do that in sepsis to see if they need steroids or not. The steroid you're going to give them is hydrocortisone, not betamethasone, not dexamethasone, not methylprednisolone, not triamcinolone. It's got to be hydrocortisone. That's where the data comes from. Remember that hydrocortisone is very similar to cortisol. So you're not asking the liver to do a million metabolic steps to convert one to another. Hydrocortisone has significant mineralocorticoid effects. So if you want to give fludrocortisone, that's up to you. It's optional. And the dose is 200 to 300 milligrams a day. So you can give 50 IV Q6 or 100 IV Q8. And the indication is, as I said, a septic shock that is resistant to catecholamines. So you already gave you gave the antibiotics. You took your cultures. You gave your antibiotics. You drained whatever needed to be drained. You gave the fluids to the point where you had to stop. You gave the vasopressors, you gave the inotropes, you gave the steroids. And now the questions are going to be, well, when do I feel okay? When do I say, all right, this patient is resuscitated? If you just say, I'm just going to do all this until I have an MAP above 65, I have a decent heart rate and a decent urine output, then you might be missing, you might be running short on your resuscitation because there might be still ongoing hypoperfusion despite the fact that you achieve good hemodynamics. So you can actually get lactate. It's not lactic acid, by the way, it's lactate, but I mean, everyone uses the term lactic acid. You can measure lactate and titrate your resuscitation. If the lactate is still elevated, you probably need to give more fluid. You probably need to give more inotropes. Check your hemoglobin. If it's below 7, you might have to actually give some red cells to increase oxygen delivery, even though they're not too effective at increasing consumption. But remember that 45% of patients with septic shock, 45% have normal lactate. So don't be fooled just by the lactate. Combine it with an SCVO2, with the caveats that I understand that we don't really know the exact value during pregnancy. But if you got a value at the beginning of your resuscitation and it ain't getting any better, then you might actually need a little bit more resuscitation. Now, you're going to need a lot of fluid in the first 1 day or 2 days of sepsis. And then most of the times what's going to happen if the patient doesn't die, what's going to happen is that after 1, 2, 3 days, you're going to run on them, and then you're going to see, wow, the blood pressure looks great. You've been able to wean the pressors. You wean the inotropes. And now all you have is a patient that is intubated, really puffy, and hemodynamically stable. So in that patient, then you can start limiting fluids. If they're making urine and the kidney is not injured, you can give them diuretics to actually get rid of fluid. And that's going to help you get rid of fluid. And if they actually are having a hard time ventilating, it'll be easier to extubate them. But that is actually late. That's in the late phase. This is actually, I just put that so you can see the fact that you can use diuretics in patients. This is patients with acute lung injury and ARDS, but remember that sepsis is the most common cause of ALI and ARDS. So you can use diuretics, but you'll use diuretics in the late phase. You will not use diuretics. If you have someone hypotensive, not making urine, don't give them a diuretic. The kidney is smarter than you all. The kidney knows why it's not making urine. And we are not as smart as the kidney, so we shouldn't come and give a diuretic because obviously you're retaining sodium and water for something. In terms of glucose control, all I'm going to tell you is that 12 years ago, everyone was super excited about keeping the blood sugar between 80 to 110. That actually kills people. The nice sugar trial showed that it increases mortality. So the current guidelines keep the sugar below 180. The sepsis surviving campaign says below 150, but the nice sugar trial says below 180. So keep it below 180 with insulin infusions. Okay? In terms of nutrition, the minute the patient gets to the ICU when they're not getting tons of pressors, because pressors cause ischemia to the bowel. But once they look like after 24 hours or so, and you'll be able to wean the pressors and you're not getting very high doses of them, then you put a feeding tube on them and start feeding them through the gut, not TPN. TPN is, most patients with sepsis are going to be able to be fed enterally. And the name of the game of the nutrition in the ICU is not a lot of calories, but yes, a lot of protein. So you need to feed them 1.2 to 2 grams per kilo per day of protein, and just deliver them like 20, 25 kilocalories per kilo per day. And again, these are guidelines from the American Society of Parenteral and Enteral Nutrition, but that's not for pregnant patients. But again, it's not going to be a big difference. If you want to give them some more calories, that's fine, give them some more calories, but don't give them 50 calories per kilo per day because that has a lot of side effects. Overnutrition has a lot of problems. And finally, in terms of transfusion triggers, as we spoke in the first slide, if you have inflammation and you have activation of the clotting cascade, and you know that these patients develop like biochemical DIC, if you want to call it, or clinical if you have the end organ injuries, the PT is going to be prolonged, the PCT is going to be prolonged, the platelets are going to drop. So if the patient is not bleeding, don't give them any blood products. Blood products are not good. They have a lot of side effects. Now, when they're indicated, they're life-saving, but don't give blood products to correct the labs. Actually, the Sepsis Surviving Campaign tells you that in the setting of sepsis and not bleeding, and you're not planning a procedure, you should not give platelets unless they drop below 5,000. And if you have a INR of 3.2 and you're not bleeding, who cares? Why do you need to give them FFP? Because you might end up with transfusion-related acute lung injury or immune modulation from the blood product. And in terms of giving packed red cells, it's extremely controversial, but most intensivists will not give blood unless your hemoglobin drops below 7 grams per deciliter. I agree that that's actually arbitrary, but that's actually the best piece of evidence available in ICU population. The best trials showed that 7 was a safe trigger compared to 10. Other things, obviously during pregnancy, and even outside of pregnancy, all these patients should have DVT prophylaxis. Electronic fetal monitoring, if it's, the baby is viable, left lateral decubitus, all that. And then if you're not too involved in these patients, the one question you'll get for sure is someone from the ICU calling or saying or questioning if it's okay to give the beta medicine or the dexamethasone for fetal lung maturity. And the expert opinion pretty much states that yes, that you can actually give it, and that's actually the one of the the latest, I guess, this month's paper on our ACOG recommendations on septic shock and sepsis. So that's pretty much what I had, and I know it's a little different, but I hope you liked it, and if you have any questions, I'll be happy to try to answer them at least.
All right, thanks for a great talk. I think that was very helpful and good, excellent review. I want to open the floor to questions. Two ways, again, to ask questions. One is select the Q&A tab at the top of the live meeting screen, and then you can type in a question, click on the Ask button, and I will forward that question to Dr. Pacheco. The other way to ask a question, if you have a microphone hooked up to your computer, select the feedback button in the upper right-hand corner of the screen. Click on to the question tab, and then I'll call on you, unmute your microphone, and you can ask Dr. Pacheco a question. While questions are coming in, once again, remind everybody, our next lecture continues what's becoming a very good research series lecture. 2 weeks from today will be by Dr. Allison Cahill on confounding and biases in cohort studies. So again, I'd like to open the floor to any questions at this point. I have one from Tufts. I missed the first couple of slides, so I apologize if this was covered, but can you briefly review maternal blood gas goals, PCO2, bicarb O2 in a ventilated patient?
All right. Yeah, that's a good question. Well, I mean, as you know, very well, you know, your bicarb is going to be between 18 to 22, and then your PaCO2 is going to be 30. So when you adjust the ventilator, you should adjust it to a PaCO2 of 30. That's what the textbook tells you. But when you actually see patients on a ventilator, most of these patients are going to be interactive. Most of these patients are going to be lightly sedated, the way you need to sedate them. You don't need to have people in a coma. And they're going to be triggering the ventilator. So, again, you know, sometimes the less you do, the better. I mean, I can assure you that to maintain a PaCO2 at 30, which is the textbook value during pregnancy, you probably have to paralyze a patient and take over the ventilator. So it doesn't really matter if the PaCO2 instead of being 30 is 25. It doesn't really matter if instead of being 30 is 38. You know, it's not going to hurt anyone. Now, there's one thing that you got to remember. If one of these patients is actually profoundly sedated or something, or they have ARDS and you use a small tidal volumes, your CO2 is going to go up. And actually, a high CO2 is actually beneficial in terms of sepsis because it has an anti-inflammatory effect. Now, the problem is going to be the baby, right? Because you don't really know what's going to be, you know, the CO2 is actually going to cross, and then you might develop respiratory acidosis of the baby or hypercarbic acidosis. So no one knows the exact CO2 value where the high value, if you're using small tidal volumes to protect the lung of the mother, no one knows what's the limit of that CO2 in terms of safety for the baby. What I will tell you, what I've done a couple of times is, because rarely I've had someone with a real bad ARDS during pregnancy, like really, really bad, especially if they're viable and you have the strip, you know, you can use a small tidal volume. If your PaCO2 goes above 30, let's say to 40, 45, watch the strip. If the strip looks okay and there's no diesels, there's good variability, you're probably all good to go. But I think my opinion is that these changes are a little bit overrated, and people think that, oh my God, you got to keep the PaCO2 at 30. It's not that case. It can go 25, 35. That should be a goal. Just like people that are not pregnant, you don't keep their PaCO2 at 40 always. If the patient wants to hyperventilate because they're slightly acidotic, they can hyperventilate and drop the CO2 to 30 or 32 or 34. Or if they hypoventilate a little bit, from 40, they go to 42, 44, 45. If they don't have ICP issues, it's not that strict. So I've never found it to be a big problem.
Thanks. Do we have any other questions for Dr. Pacheco? Well, I think doesn't look like we have any other questions. So I'm going to thank Dr. Pacheco again for a great talk. Hope to see everybody back here again in 2 weeks for the next research lecture. Do have one more question. From UNC Fellows, do you have a specific antibiotic that you suggest? I guess that's in the septic patient.
Yeah, well, you know, it depends on what you're treating. You know, if you're treating pneumonia from the community, then you want to probably do a combination of like azithromycin and ceftriaxone. If you're treating pneumonia in the hospital, like a nosocomial pneumonia, you might want to do something like sosine and vancomycin. What I can tell you, though, is that I think many times us as obstetricians, we don't realize that there is a lot of variety of antibiotics. So we tend to use a lot, and there's nothing wrong with it, but in some situations, you know, amp, Jensen, clean, that might not be the best thing. For example, for abdominal infections, the Infectious Disease Society of America doesn't recommend the use of clindamycin anymore for anaerobes. They recommend metronidazole because of the resistance of Bacteroides fragilis to clindamycin. The use of Unicin, for example, they don't recommend Unicin anymore for E. coli. So there's a lot of other options. I would probably tell you that, and I don't want to just give you like a recipe, but if you have someone really sick and you want to use something different for whatever reason, if you do a combination of sosine, which is piperacillin and tazobactam, with vancomycin, you will be covering pretty much everything. You will be covering Pseudomonas, you'll be covering MRSA, you'll be covering anaerobes. So that's a good empirical coverage. But again, I wouldn't do that if you're treating someone with chorioamnionitis, where probably just ampicillin and gentamicin would be okay.
Great. Well, thanks again for a great talk. And we'll hope to see everybody back here in 2 weeks.
Thank you so much, and it's been a pleasure. Thank you for having me.
Thanks. It was a great talk. Appreciate it a lot.
All right, my pleasure.